Michigan Department of Health and Human Services. So thanks to all the MDHHS folks that are joining us today online. And we have in person also with us Dominic Smith, who's the section manager for public health genomics at MDHHS. So Melinda, I'll give it to you for the intro, but thanks everyone for coming.
All right, great. So Dr. Hulihan is a health scientist in the epidemiology surveillance branch of the Division of Blood Disorders, National Center on Birth Defects and Developmental Disabilities, Centers for Disease, at the Centers for Disease Control and Prevention. Currently, she is the project officer for the cooperative agreements characterizing the complications associated with therapeutic blood transfusion for hemoglobinopathies and the sickle cell data collection program, which provides support to 11 states to design, develop, and implement the first population-based sickle cell disease longitudinal data system that collects demographic, clinical, and healthcare utilization information over an extended time period. Dr. Hulihan received a bachelor's in biology from Emory University, an MPH in epidemiology from the George Washington University, and her DRPH from the University of Georgia. So now I'll turn it over to Dr. Hulihan.
Thank you so much. I'm gonna. This is working, but it's not. It was a little slow for me last time, so. It's not, yeah. There we go.
Up to that, we see. Okay. So when Dr. Reeves invited me to give this talk, she said that y'all were a little tired of hearing about the sickle cell data collection program. So I shifted it a bit, and the focus is still going to be on sickle cell disease, but it's the relationship with invasive pneumococcal disease. And while that's a lot of the information that I'll be presenting, the real take-home message, or I hope what is the real take-home message, is the importance of multidisciplinary partnerships to understand health. Given the audience that is here today, and given the work that we do as part of the sickle cell data collection program, I just don't think it can be underscored enough how important it is to have many different perspectives on a project, to have respect for the different experiences and expertise of people participating in a project, and to not stay just in your area of expertise, but really do what you can to try and to kind of broaden your knowledge base so that you can have meaningful conversations and meaningful interactions. So at the end of the day, you meet your goals and objectives for your project. So all of that is to say there's going to be a lot of data up here. There's going to be a lot of numbers. That's not the goal of today's presentation. The goal is to think about all of the different groups who put that information together to kind of get us to where we are today. So a quick overview of multidisciplinary partnerships, the connection between sickle cell disease and invasive pneumococcal disease, and then hopefully bringing home the message of why those multidisciplinary partnerships are so important in public health. So what are these partnerships? It's really thinking about how we approach public health. Are we looking at it as though there's a specific challenge and small scale efforts with a siloed perspective? I think for a long time, that is how public health functioned. You were an epidemiologist, you thought about the epidemiology of the project and didn't necessarily think of how those findings were going to be translated by health communication experts, by people thinking about behavioral health, by people thinking outside of public health, clinical health, general communications with the public. And so that notion on the left is, I hope, is really moving out of favor and moving out of the way that projects are designed into what you see on the right, which is really thinking about complex challenges, thinking about bigger pictures, how you can create an infrastructure for a program that's collaborative, and very much importantly, bringing in various perspectives to the program to try and achieve your goals. And so there's a lot of work out there. There's a lot of research, but this is just kind of one of the things that really resonated with me about strategies to enhance multidisciplinary teamwork. And one of the ideas is thinking about what can you do to promote what works and to promote what moves things forward, and what can you do to stop what is causing barriers and causing hindrances to your progression. And so on the left, they came up with this really cute teamwork, and that's great, but there's some interesting things in there that, you know, as I've been working with our sickle cell surveillance system for about 14 or 15 years that really resonate to me. I think motivation is a huge one, and I don't think we always take into account how to keep the team members motivated. And that can mean a lot of different things. It can certainly mean team building. It can mean, you know, sharing the progress with people external to the team. It can mean, it can mean financial encouragement. It can mean progression through a career, things like that. And then kinship is the other one that I thought was interesting that they included on here, but thinking of projects that I've been a part of, or, you know, I'm not, you know, aware of when they really work, there is some sort of very unique bond that's created among all of the different people working on the project. We had an in-person meeting a couple of years ago, and the Anne Shookett, who was at the time the acting director of CDC, came in, and it was the start of a project, and she said to everybody sitting there, she said, look around because you're going to really get to know these people. She said, I've started a project, and by the end I was somebody's child's godparent who was a part of the program. I was, you know, I mean, and so I think that it is that kinship that builds that really allows there to be success. So look around the room because they will become your friends. And so just some examples of multi-solving projects. I'm not going to really go through this, but I think the principles and the practices are important, that everybody matters, everyone is needed. You're not putting people at the table just to check a box because you were told they needed to be there, but they really are important. You don't need to stick to the easy problems to address. Sometimes it's those tough problems that really be the most successful. And that doesn't mean you need to address the tough problems by going all in at the very beginning. I think a lot of times you can have small solutions and small growth, and that leads to really impressive outcomes. And then the three practices that are really important, that it's a welcoming group to work with, that there is learning along the way. You're not just there to educate others, but you're there to be a part of that team so that you're learning yourself. And that there is a lot of sharing of information and not necessarily just throwing data up and letting that tell the story, but integrating how your data and your collection of information really applies to the whole process. There's also cross-sector collaboration. I mean, these are all just different terms that to me at the end of the day mean a lot of the same thing, but it's all about using differences to be the asset. You really recognize that those differences, again, are not just there because you were told they need to be there. You're not just including the policy people because, you know, they might talk to a commerce person at someday, but you're including people with all of these different perspectives because they really can't lead to better outcomes. Okay, so keeping all of that in mind, thinking about multidisciplinary teamwork and practices, moving on to this example of sickle cell disease and invasive pneumococcal disease. So just a very quick overview, what is sickle cell disease? So there's different types of hemoglobin that affect how red blood cells function. And the type of hemoglobin that you inherit determines whether or not a person has sickle cell disease and the type of sickle cell disease they have. And so on the left, you can see when someone inherits sickle hemoglobin or hemoglobin S, it causes the red blood cells to stick inside the blood vessel. That blocks blood flow, it blocks oxygen supply, and that occurs throughout the entire body. And so you can imagine when you're blocking blood flow and oxygen supply to every single part of your body, very bad things result. And that's in difference to individuals who have normal hemoglobin or hemoglobin A, which allows those blood cells to be flexible, to flow smoothly, to get where they need to go in the body through blood vessels without getting stuck. Okay, so what happens when the blood cells get stuck with sickle cell disease and kind of all the other permutations? So when it's blocked, individuals have these sudden and severe pain. They're called sickle cell crises, pain crises. They can be life-threatening. Again, those crises are happening because the blood flow is blocked. And so when the blood flow is blocked to your brain, it can cause strokes in the lungs. It can cause acute chest syndrome, which is really another thing for basically pneumonia in people who have sickle cell disease. It can cause chronic organ damage, in the spleen and the bones and the kidneys. Again, anywhere that blood flows in your body, sickle cell disease can have a pretty impactful effect. And so it's severe, it's lifelong, and the other challenge to sickle cell disease, in addition to affecting all parts of your body, is it's very difficult to predict. Somebody can be doing just fine in the morning, and by afternoon, they're in a severe crisis. They're in the emergency department. Things can go wrong very quickly. And so it's that difficult prediction that makes it hard. So that's all just a little bit of background there. And so just again, to give you a bit of a historical perspective, back in the 1970s and at times before the 1970s, the age at death for people with sickle cell disease, you can see in those dotted lines, was pretty high. There was a large percentage of the population dying in those very young age groups. That curve then kind of goes downward, and in the 20s and 30s starts picking up again. But focus for now on that pretty severe incline that occurs in children in those very young ages. And so again, not that long ago, this is what kind of the age at death pattern looked like for people with sickle cell disease. And so why was that happening? And, through a lot of epidemiology and really looking at things from a population perspective, it's because children with sickle cell disease were dying from severe infections. That was not the only thing killing them, but it was a huge part of it. Again, you can see various causes of death and infection there, but if you look in those very young age groups, you see that really high spike for both meningitis and sepsis. And again, you then note that those infectious causes of death decrease quite a bit after those young age groups. And so, one would make note that there's high mortality in those young age groups. There's also high severe infections. So what can we do to stop infections? Well, just as with anyone, penicillin is often a course of defense against infection. And so based on that information they had in the 70s, by the mid 80s, there was this clinical trial looking at prophylaxis with oral penicillin in children with sickle cell disease. And so starting at 4 months, the study recommended penicillin prophylaxis given on a daily basis to children identified with sickle cell disease. And this is looking at your y-axis, the cumulative probability of infection. And you can see the solid line, children who did not receive placebo at quite a high probability of infection, especially compared to the children who were on the penicillin prophylaxis regimen. And this was a huge study in the world of sickle cell disease and resulted in what is now the recommendation is that children who have the most severe form of sickle cell disease are started on penicillin prophylaxis on a daily basis from about 3 to 4 months up until they reach the age of 5. And again, the entire purpose of this was to prevent those early deaths and those early severe infections. So if you think about who had to come together, have these conversations, and why multidisciplinary teamwork was important, you had the physicians noticing that the children were dying. You had the researchers thinking about how to conduct clinical trials. You had the parents of children saying, my kids are really sick with these infections. It really had to be all of these different groups coming together in order to get to the point of understanding the importance of this prophylaxis. So the next step was we know how to identify a child with sickle cell disease. It's a fairly simple screening test. We know that penicillin prophylaxis, when you give it to them very young, really helps to prevent those severe infections. And because of that, in 1987, the National Institutes of Health convened a conference looking at newborn screening for sickle cell disease and other hemoglobinopathies. And they concluded that every child in the United States should be screened for hemoglobinopathies to prevent potentially fatal complications of sickle cell disease during infancy. And so the whole purpose of that was to identify these kids with newborn screening, really. And a big part of it was to get that penicillin prophylaxis started immediately. So you'll see that the consensus conference was in 1987. States are allowed to put which conditions they want to on their newborn screening panels. And so it was not until 2006 that all states actually started screening for sickle cell disease at birth, but as of today, all babies born in the United States are screened. And so who had to come together, you know, to have these discussions? So we already had the physicians and the parents, and we had the epidemiologists doing their studies. And here for this conference, there was a lot of policy that had to come in. There were health departments that had to come in. There were newborn screening programs that had to come in. And so they had to, and you can see it's a consensus development conference. It wasn't just one group saying this is what should be done. It was really all of them coming together, coming to agreement and saying this is what we need to do in order to have a better outcome for these children. Okay, so remember 2006, all children in the United States are now screened for sickle cell disease. And if you look at the solid line of what the age at death for individuals looks like, you can see that big spike that was used to be seen in deaths for children with sickle cell disease is pretty much wiped away. And I think anybody working in public health can look at this as like a prime example of how important newborn screening, which is one of the most successful public health programs, is. This is a very specific population, but this implementation of newborn screening really did what it set out to do. And I don't think that all of us, you know, are always able to see when these great ideas are put into practice that they do what they were intended. But in this case, that's certainly true. We could have a whole other series of conversations about those horrible, you know, big spikes that are still in the 20 to 30-year-olds. That's a totally different conversation. But today we're just going to focus on the good thing, which is that young age group, the age of death, or those deaths pretty much disappear. Then looking at clinical practice, so we now know that there's newborn screening. We know that if we get these kids on penicillin, that it really prevents deaths in that early age group. But we have to make sure that physicians are implementing this practice. And so moving forward a couple of years in 2014, this expert panel report came out from the National Heart, Lung, and Blood Institute looking at evidence-based management for sickle cell disease. And there's 3-step prevention strategy in there, and it's basically what we talked about. You start the penicillin prophylaxis, you continue it through age 5, you also give vaccinations against pneumococcus and other pathogens. And really important, you educate those with sickle cell disease and their parents and caregivers regarding the need to seek immediate medical attention in the event of fever. So we need the doctors to do the prescribing of penicillin. We need there to be places where you can receive vaccinations for these agents. We need parents to understand that their child needs these preventive measures and knows where to go to receive them. So although these evidence-based management is really meant for healthcare providers, even within something that's written for the medical community, there's talk of health education, a completely different part of public health. There's talk about provider or parent and caregiver education. So again, even though this seems like it's a pretty focused audience that this is targeting, you really have to think about ways to do all of these different strategies in order for there to be success. So has there been success in implementing these evidence-based management? What we're going to look at is, have there been success with the vaccination strategy? So we already talked a little bit about the penicillin prophylaxis. We're going to move forward with the vaccination. Okay, so here comes a whole new group into this conversation, the Advisory Committee on Immunization Practices. You may never have heard of them before, but I'm guessing in the last 3 years, they've been a little bit more, common knowledge. So ACIP, they're the group they are a very multidisciplinary group themselves. They are physicians, they are advanced practice providers, they are nurses, they are healthcare administrators, they are all different groups of experts that come together and decide what the immunization schedule should look like for people in the United States. And so it's so you know what the series is that your child should get of their shots when they're little. And so you know that, you know, as people age in the aging population, how the vaccination schedule differs. There's what is to be done for the general population, and then there are also some special situations in these ACIP guidelines. And one of those special situations, going back to the conversation we've had, is what to do for people with sickle cell disease and hemoglobinopathy. And so if we look at that vaccine, the vaccine recommendation on the previous page, it's that they need to have their PCV and PTSD 23 shots, and that they need to be updated as new variants emerge. So what did hospitalizations for IPD look like for children in sickle cell disease after the vaccine licensure? So once the PCV vaccines started being, or the PCV vaccines started being given in about 2000, it was PCV7 at the time, there was nearly a threefold reduction in the number of hospitalizations, 53% reduction in days in the hospital, 36% reduction in hospital charges. So ACIP came out, they put out these recommendations were implemented, and again, very soon you started seeing these drastic effects. What do the actual cases look at? The previous page was hospitalizations, but are the cases going away? So this is a paper that was put out by a group in Texas in 2011. Just looking at their own patient population, they saw a sharp decrease in cases and an increase in cases over time. And that seemed strange to them. We now have this vaccine, but all of a sudden it went away when that new vaccine was introduced. And now we're starting to see these numbers creep up again. So here comes another player, the active bacterial core surveillance. So this is a very laboratory focused group. They are bench scientists at CDC. They look for invasive bacterial pathogens of public health importance throughout the United States. And so there's a couple sentinel groups that are funded to do this. You can see that collaboration again at CDC, state health departments, universities, and they currently conduct surveillance for 5 pathogens, including Streptococcus pneumonia. What you see at the bottom is the case report form. It's really tiny because I didn't want you to spend too much time looking at it, but in that red circle, there is a box to check for, and when someone has one of these 5 pathogens, whether or not they have sickle cell disease. So, great resource for information. How can we find out why that spike started going back up again in children after the vaccine was introduced? So this is a study by some colleagues at CDC along with that ABC team. And what they found is, although the PCV7 immunization was introduced, what you were seeing in the kids with sickle cell disease were variants that weren't actually in the PCV7 vaccine. And so it was working, it was getting rid of those PCV7 variants, but there were other variants that were not yet in the immunization that were actually causing the problems in children with sickle cell disease. So, is this because, you know, it's part of the reason that we're seeing this uptick in children with sickle cell disease, because they're not getting their vaccines, because health education hasn't done a great job, because we haven't changed people's behaviors, we haven't, you know, implored them to get the necessary medical coverage. And Dr. Reeves and her group here looked and found that's actually not the case. People with sickle cell disease, children with sickle cell disease get immunized at higher rates than the general population. So that's not really the issue here. So this is a recent study furthering looking at that. This has not been published yet, so there's no numbers, but there are now new variants of the PCV vaccine. 13 is the current recommendation. 15 and 20 are being looked at for adults. I think it just came out last month. For adults, they're now starting to look at this as being the recommendations for children. At the time the study was done, PCV13 was the recommendation. Again, in this study, and I don't show that here, but comparing sickle cell disease to non-sickle cell disease, you're seeing a lot higher rates of IPD in the children with sickle cell. But when they looked, The PCV13 variants, which is what was recommended at the time, were still really low in the kids. So they're getting their immunization, they're getting all of the care. You know, everybody's doing what they're supposed to. It's those variants that aren't yet in the immunizations that are actually what are causing the cases of IPD in these kids. So it's what would be in the PCV15 and the PCV20. The good news is these are the ones that are currently under the ACIP is currently reviewing to see if they need to be recommended, again, in a special situation for children with sickle cell disease. And this is exactly the kind of data that they use, and it is now going to be available for them to hopefully make a change in their recommendations. So here, again, the take-home message today. We talked about a lot of different groups that have contributed to the success. There's not a lot of successes in sickle cell disease, but this really is one of them. And I just cannot underscore enough how important it is to have all of these different players at the table. And at the center of it all being the parents and caregivers, because you can do everything you need to do. You can do all of the right studies. If you don't have people there who actually have a child with sickle cell, who take care of a child with sickle cell, you do not know what strategies are going to work best. You do not know how to create materials so they understand the importance, how to create opportunities so they have places to go and get the immunizations and get the penicillin for their children. If you don't have that perspective really at the heart of everything you do, you can have the greatest study and it can completely go to waste because it's never going to get implemented and it will never be taken up. So that is my talk for today. Hopefully a lot of different words whizzed by you, and that really, again, was not the important part. The important part was thinking about all of these different brains and all of these different perspectives having to come together to make the success really that this whole journey has been.
So now we'll just open the floor up in the chat or those that are online to any questions. Are there?
Question. Thanks for that great time and the history of what is happening with prevention and treatment of individuals with sickle cell. I wonder if you could talk a little bit more about, you talked about the multi-disciplinary approach to implementing antibiotic prophylaxis. I can imagine how challenging that might be for families to keep their children on antibiotics through age 5. And so if you could just talk a little bit about what some of the challenges in learning areas of learning for parents.
Yeah, great question. So I think, and probably for not just for sickle cell disease, but for a condition that affects people for a long period of their life, where they are having to see a lot of different people within the healthcare system. I think just making sure that it's not just primary care providers, it's not just hematologists that are aware of recommendations, that are aware of best practices, but making sure that that information is going out to all sorts of healthcare providers is a huge part of it. Because the more consistency that a family can hear, regardless of when they're touching the healthcare system, is really key. I think it would be extremely challenging if one doctor was saying, oh, yes, the penicillin is really, important. And another doctor was saying, oh, well, you don't want to get them penicillin resistant by the time they're 5. And so I think making sure everybody is getting the same message. And that is a huge part of the role of public health, is to do a good job in that messaging. And I think that's probably one of the biggest struggles that public health has. So I think that part is important. I think that making the prescription process, the receiving of prescriptions, the receiving of medications as seamless as possible is also really important. If a family has to think about everything else going on in their lives and know that for 5 years they have to keep their child on a medication, making it as easy for them to access that medication is really important. And so that means that their insurance company has to provide ways for mail prescriptions. Does that mean that a lot of these children are Medicaid beneficiaries. Does that mean that there needs to be community health workers inside Medicaid who are working to remind the parents about the importance of these prescriptions, to see what are the barriers in getting the prescriptions and see if there are ways to overcome them? So I think, you know, it really is just kind of every piece of the whole together with that.
And so, David, you had a question, or you have your hand up?
Yeah, thank you very much for the presentation. I'm particularly interested in the engagement of patients and parents, and how one does that in the most meaningful way. What I see in a lot of circumstances is that it's obviously or frequently a convenience sample of those patients or parents who are already very strongly involved in sort of supporting patient care, and they aren't necessarily representative of the population. And the other thing is, when we're talking about doing research in a particular medical condition, how does one prepare patients or parents for conversations with researchers or public health specialists so that they feel that they're on an equal footing?
Yeah, that's a great question. And I absolutely agree with you that oftentimes you receive feedback from the most involved and perhaps not the perspective of the community that is really what is most needed. And because often what you really need is the perspective of people who aren't so immersed in the healthcare system, or who aren't so aware of new research that's going on. I think that's a big challenge. I think that's an area that we really need to better understand and better think about. So I certainly agree with you, but don't have an answer to the first part of your question, although I'd love to talk about it more and brainstorm about it more. The second part of your question, I find that we get very frustrated when we start a research project and invite members of the community, invite, you know, people with lived experience into the research project and don't get the feedback or the information or the participation that we were hoping for. And I think that's because we as researchers are doing a terrible job of not engaging with the community we're interested in until we have funding to do a research project, until it benefits us to have them a part of it. And so what I think is, if you're working in a particular field, if you're working with a particular, you know, geography or demographic, it's incumbent upon either making yourself well known and respected in that community, or making sure that you also have as part of your team, groups or leaders who are well respected and who are already part of that community. And so whether that is bringing faith leaders into your team, whether that's bringing school principals into your team who have nothing to do with the condition or really the project that you're working on, but work with the community and know the community that you are, I think that's a great way to do it. But I also really think we have to stop just engaging with people when we need them. We need to remember that we need them before we have grant funding and before we have a particular research project, and keep them engaged in gaps between our research and gaps between our funding. So I think it's probably it's our fault for not having better perspective and better engagement in the project.
Can I follow up on that? So that's a perfect segue into the question that I was going to ask, which is about sustainability of these relationships. So just for context, I've done a lot of community-based work in asthma, and the key is the relationship. You know, that point they just made about maintaining the relationship and not being opportunistic about it. And that takes time and it takes investment, and what it also means is that when your partners come to you with a priority that maybe isn't exactly what yours is at the moment, that there's a reciprocity there, and that as a researcher, you're devoting some of your time to meeting whatever their priority and their needs are. And our system is really not set up to support all these team members that you were talking about in those adjunctive activities. It's one thing to maintain a group of professionals that are used to sort of coming together and disbanding and coming together and expanding, and you'd like to keep the same people involved for continuity, but sometimes we don't have that luxury. But I think when you're dealing with either community members or patient advocates or family members, the continuity becomes important. And in your little teamwork mnemonic where you have, the relationship piece was really important. Do you have any insight or comment about how we can make that space for us as researchers and professionals to be able to devote the time to that, and how funders or funding needs to change?
I mean, that's a great point. I can say I'm silly, but that's probably not the most pragmatic response. I will say that I see a change in the way projects are being funded, at least within CDC, and I can't speak to NIH or other agencies. There is a huge emphasis on community participation, community feedback, patient-centered outcome. I think with Corey, with all of that, I think this patient-centeredness is really a focus. And I think it seems to me that the people who actually make decisions are also hearing and understanding that importance. I think researchers have again, it's falling a little bit on you to say, this project is asking you to do X, Y, Z, but it's not keeping the patient at the forefront. So we need to think about how to do that. So it's more communication, it's more conversation. I can tell you for our project, which is a data collection program, when we didn't know what our funding was going to be, us at CDC who run the program said we were going to stop collecting data, and that we can no longer have our community outreach work group as a part of it. So, and people seem to say, yeah, because we finally have this relationship and it was together to lead to the project to drop it. So I think sometimes it's pushback, and that's not always easy to do. And I know I have a completely different perspective as the one putting the money out versus the one receiving the money, but I think it is a group conversation from the people who make the decisions to start having that conversation. And then as far as keeping the long-term relationship, we fall into this pattern of thinking, I'm only going to share information when there's something new and important, or I'm only going to put something out when I have, a latest finding to share, or there's something big. And I think maybe we need to change our mindset that sometimes you can send someone a text and just say, hey, how are you doing? Not, it's a baby. Think about just maintaining conversation, that could be consistently low-level conversation, even if you're not in a program, you're going to have something coming up. So I think, again, it is kind of on the researchers' shoulders, but think about ways you can engage with somebody with a huge impact. It seems to be successful, but I don't know.
Can you talk a little bit about, you touched on this a lot, but building trust in the process of building trust, especially coming as an outside researcher into a community that you may be very different from?
Yeah. I don't know. Sticking around I think that's the best way to build trust. I think it took a long time. I just my own personal experience, I started on this project and I had people stand up in the room and yell at me because why would the government be collecting data when we could be saving lives? Why, it was terrifying and traumatizing. And I thought, why in the world did I say I would do that? But there's also, if you're doing something and you know it's the right thing to do and there is real benefit to doing it, I think you have to be strong and feel confident in what you're doing and be willing to have the same conversation over and over and over and over again to let people know you're there for the long haul and you're not there just because you have a 3-year grant and you are going to stick around. And that's really hard because we don't all stay in the same career. We don't all stay in the same space. I don't think there's an answer to it. I think there are things we can do to make it better. But it's very hard. Seeing the same face or faces over and over again is really impactful when people think about, oh, here's a researcher coming in. But I've seen you for a long time and I've not heard you, and you don't seem to be going away anytime soon. But it seems to, but it's like building a friendship. You have it a long time.
Mary, I have a question. Thanks again for your talk. This is great. So I have a lot of questions, but I'll just ask one. So just sort of is a continuation of Dr. Lewis's sustainability question. So you mentioned about things sort of changing at CDC, and I can say, since one advantage of being a home person is you've seen a lot, and it actually seems to be happening. I worked in asthma for a while, sickle cell, working Flint registry, and there are changes going on, which is good. But can you just clarify, and maybe we have all the answers here, like at what level in the CDC do some of the things happen that you're talking about, which are these changes? So you describe pushback, which I think is really important, but is this like the CDC director decides, or is this a congressional thing? Where are these decisions made?
I think it depends. I think there are people who think they make the decisions and they may not be the ones who do. So I'm not going to maybe not answer your question. I will see what I say, what has been successful, what has proven successful. Right now, and I say right now because I don't know, 30 years ago, HIV, AIDS were, incredibly important. There was PEPFAR money, there was all of that, and that was like this huge topic. And then I would not say the interest went away. It has always been a huge program. There has always been a lot of money in HIV programs at CDC, but kind of the constant talk about them, kind of constantly hearing about them has went away. And all of a sudden it is back big time. They have gotten so much money and now it's all ending the HIV epidemic. That is the big break. And that came because there is a completely external advisory board that advises CDC on what to do about that. And it is made up of clinicians and public health workers and people living with HIV. So again, this is my very lowly perspective. I think external input is incredibly important when it comes to CDC.
So is that an advocacy thing? Is that like an HIV specific group?
I think, yeah, there is. There's a very specific HIV group, but it depends for other groups too. We work very closely with the American Society of Hematology, the Division of Blood Disorders. What they say and what they hear and the conversations they have with us are incredibly important in thinking about what is really needed in the hematology field these days. So again, the work, I really think external groups, external input, sometimes it's because a single parent has sent a letter and somehow gotten it to the CDC director, and all of a sudden it makes a big change. And that comes down to us, and we have to make, things a priority. So it is all the way from a single individual level. I don't know how you get that letter to the right place. I think it was working with state legislator. I don't know. But then I think there are these external advisory groups that really have a lot of and I think that's appropriate. I think that's where the input should come from. I don't think scientists and researchers sitting in an office somewhere should be making decisions about drugs for the United States.
That gets back to the trust issue.
It does. It does. It also makes your project so much easier to present to the community you're working with, to anybody, when you can say that this idea came from people living in this world. This is not us making these decisions. It makes it a lot easier to garner support from people you're working with.
So on the question of trust, so it seems to me that the CDC has had some difficulties recently. I guess the first piece was some blowback against the opioid prescribing guidelines, of course, followed by the politicization of COVID-19. So I wonder if, in your experience, have you say, hey, I'm from the CDC and I've people in the community, does that become a liability?
Oh, it's a great question. So it very much goes into trust. So I would say, is it a liability to say I'm from CDC? Not with people that I've worked with for a long time. I think again, there's kind of this historical perspective but I'm sure, I mean, I feel like I tell when, the person at the grocery store that I work at CDC, sometimes it's looked at with like real not happiness, but yeah, and I think it's on any agency that is federally funded, when there have been real breakdowns in trust, it's that agency who has to fix it. And I will also say there is a lot going on internally to make some serious changes within our agency, both in terms of infrastructure and in terms of our website, the way things are communicated. And so, but again, I think that's because of the input they received from people genuinely concerned about the legitimacy of what's coming out of the federal agency. So yeah, it depends on your relationship with somebody. As to how they view the place of employment. For our project, for this sickle, it has not been an issue, but I think it certainly has been for many other groups.
So we have about 4 minutes left, and so we can't get any more questions that may pop up, but I wanted to grab everybody's attention, or draw your attention to the screen. If you could take the survey, we would greatly appreciate that, and just access it through the QR code. And I think let's put in the chat as well.
Yes.
Okay, and put in the chat as well. And so if we didn't have any other questions, thank you, Dr. Hulihan.
There's also more food out there.
And for those in the room, there's more food outside the room that you can access. But again, Dr. Hulihan, thank you so much for the presentation and for the questions. That was great.
And I think there's
all of them.